Welcome to Shift, this kind of snowy January day. I'm really pleased to have Tim Mueller here, our pharmacare consultant. As Adam mentioned, he's brilliant, and we're lucky to have somebody of his experience and knowledge join us. We talked in worship a little about spiritual growth and exercising with our water words. And now we're talking a little about our bodies, because if our bodies don't work as well as they could, or we're in pain, it's hard to even be spiritual sometimes. So the topic today is arthritis. Tim presented some of the findings at a Trinitarian group, but we thought we would expand it a little bit and see what your interest is. So I'm very glad that you're here. Welcome, Tim.
Thank you. Good morning, everybody. I was approached about 2 years ago by the Trinitarians about putting together a health series for them. And they asked me if I would do that, and I said, yes, that's not a problem. We just have to figure out what to do. So what I did was I had some ideas, and I went and looked at some paperwork that I have from the Mayo Clinic and from the National Institute of Health. And since it was the Trinitarians, the National Institute of Health has the top 10 items or categories that you, the senior citizens, are most aware of and most concerned about. So it wasn't too tough. I don't have that with me, but I would tell you that the number 10 was dental. Number 1, I think you can guess which one it was, and that is Alzheimer's and dementia, which we did a presentation to the Trinitarians last year. So this year, I gave it still some thought, and then I looked at the list again, and I thought, oh, there's number 5 on the list, which is osteoarthritis and rheumatoid arthritis. These are the things that you are most concerned about as senior citizens. Osteoarthritis has been a growing thing, especially with our age group. I'm included in this group too, so we all kind of suffer with this together. There's over 30 million people plus with osteoarthritis, and there's 1.5 million people with rheumatoid arthritis. I know a lot of people in this congregation that have talked to me about rheumatoid arthritis and where we live up in Maple Grove. So I've got a lot of experience with them, and I'm still actually an active pharmacist, but I do consulting work for a lot of people, for nursing homes, and did that for a lot of years. I attended in the 90s, it was a 2-year, I shouldn't say seminar, but 2 years worth of study down at Mayo Clinic, where I drove down every other Thursday for 2 years, had classes from 8:30 in the morning until 12:30, and we had all these modules. We had to do cardiology, gastroenterology, etc. And then in the afternoon, I would go on rounds with medical students who were 20 years younger than me and residents. So that was really interesting, and that's when I became also a consultant pharmacist too. So it kind of went hand in hand. So, but anyway, so we'll go ahead and start here, because this is in a lecture format. I know it's not a typical shift that we do, but Jerry had asked me to do this, and I'm more than happy to do that. When we put this together, I wrote this pretty much, and you know, there was my lovely wife, Betty. All the slides that you see, she typed everything in, and she put her little artistic touch on some of these, so to make it kind of fun. So you'll see some of those things. So anyway, we'll start. So osteoarthritis is the most common form of arthritis, affecting 30 million people worldwide. It occurs when the protective cartilage that cushions the ends of the bones wears down over time. So we're going to remember that it's cartilage that it's decreasing. Although osteoarthritis can damage any joint, the disorder most commonly affects joints in your hands, your knees, your hips, and your spine. Osteoarthritis can usually be managed, although the damage to joints cannot be reversed. Staying active, maintaining a healthy weight, and receiving certain treatments might slow the progression of the disease and help improve the pain and joint functions. Next one, Betty. So what we're going to talk about here, we're going to do an overview of the two. I'll talk about the symptoms of each, the causes of osteoarthritis and rheumatoid arthritis, the risk factors that are involved, and they're pretty heavy with rheumatoid arthritis, believe me. Complications, and we'll talk about OTC medications that you can use for the osteoarthritis. Rheumatoid arthritis is done, and I'm gonna introduce you to some new language here that you're gonna see in ARP magazines, Arthritis Foundation magazine, etc., and from Medicare. So they're looking at what are called biosimilars and biologics. These are new types of medicine. I'll explain them to you. I'm not going to go into great detail, but at least you will have heard about them, and you'll kind of recognize that. So for osteoarthritis, next one, Betty. Oh, okay. The pain, the symptoms include pain. Affected joints might hurt during or after a movement. You have a stiffness, joint stiffness, might be the most noticeable upon awakening in the morning, or after being, inactive for a while. You're sitting at a desk, a chair. That's when you're going to notice the most. You have tenderness. The joint might feel tender when you apply light pressure to it or to near it. Loss of flexibility. You might not be able to move your joint through its full motion. Grating is kind of a grinding sensation. You hear that? Bone spears, extra little bits of bone which feel like hard lumps can form around the affected joint, and swelling. This might be caused by soft tissue inflammation around the joint. So if you have a lot of joint pain and stiffness, you might want to go have your doctor check it out. So, causes. Next one, Betty. Okay, so the two main types of arthritis, osteoarthritis and rheumatoid arthritis, they damage the joints in different ways. Osteoarthritis is the most common form. It involves wear and tear, damage to the joint's cartilage. So the cartilage that's on the end of the bones is essentially eroded away, and then you're bone on bone. This also causes deterioration of the connective tissue that are on the sides. I'll show you a graph of that, and attach the muscle to the bone and hold the joint together. So it's doing a fair amount of damage over time. Rheumatoid arthritis, the body's immune system, your immune system mistakenly attacks your muscle and your joints, okay? There's a lot of diseases like myasthenia gravis and et cetera that I help people with they attack the muscles and they lose all muscle function. So we're talking about the joint here. So we have cartilage on the first one, wear and tear, and we have on the lining of the synovial membrane, which goes around the end of the bone, which becomes inflamed and swollen, and it leads to destruction of the cartilage and the bone within the joint. Okay, so two different mechanisms there, but the immune one can affect a lot more than just bone, believe me. So, next, Betty. Risk factors. Older age, obviously, we experience that. Obesity, carrying extra body weight contributes to osteoarthritis in both of them, and the more you weigh, the greater your risk. Increased weight adds stress to the weight-bearing joints, as we probably all know, such as your hips and knees. Joint injuries. Injuries such as those that occur when playing sports, the old football injuries, those type of things. Just broke your ankle when you were younger skiing, etc. Those come back to haunt you in time. You more than likely, a great percentage will, if you broke something 30 years ago, you're going to feel it now. So you're going to start feeling the soreness and everything in the wrist. So the joint injuries are important. Repeated stress on the joint. If you have a job that you are constantly moving your wrists arms or something like that, or sport that you play like pickleball or something like that, those type of injuries with repetitive stress on a joint, that joint might eventually develop osteoarthritis. Genetics. There is, some people inherit a tendency to develop osteoarthritis and bone deformities. Some people are born with malformed joints or defective cartilage right out of the chute. So, Betty, you can hand out these. So I've got a handout here for you. Betty's going to hand them out to you. What I did is put this together so you've got some notes here for yourself. And so I can go over these, and then we'll start with a little bit of rheumatoid arthritis. So right now, you know the difference. Try to make it kind of simple. So as soon as you see these, this is on your sheet. So I did a osteoarthritis versus a rheumatoid arthritis. These are chronic conditions that become worse over time without appropriate treatment. Osteoarthritis is easier to treat because it usually affects fewer joints. Fewer joints than rheumatoid arthritis. Whether you have either of these, it is important to know that treatments have come a long way, and I'll show you some of those. But the first step to the road to getting better is getting a proper diagnosis. My osteoarthritis, I go to the clinic in Alina, and the gentleman, the orthopedic surgeon has done my knees, both my knees and everything, and I was talking with him, and he has told me that people come in thinking they have just arthritis, but they actually have rheumatoid arthritis. It's a lot worse than what they thought. So you need a proper diagnosis, believe me, because it makes a difference. The problem with rheumatoid arthritis, it mimics a lot of other diseases. So that's why you need to see a physician. So if you look at the chart up there, see if I got mine here. So on the left, the osteoarthritis, again, remember, is a degenerative disease, wear and tear. Rheumatoid arthritis is an autoimmune disease. Your immune system mistakenly attacks that joint, your joints, fingers, hands, knees, whatever, or hips. The onset for osteoarthritis, it develops gradually over years, as we know, as the joint cartilage just essentially wears away. The onset for rheumatoid arthritis can be within months or weeks. You don't know. All of a sudden, you're going to have all these, the people that I've talked to and the seminars that I've sat in on, it worsens over 7 weeks. They'll get the stiffness, the soreness, and everything, and all of a sudden, boom, they can't move their wrists. They get up in the morning. Affected osteoarthritis, again, is over 30 million people. Compare that to Alzheimer's, which is 6 million people, and you can see that that's a lot of people, including almost everybody probably in this room. Rheumatoid arthritis is about 1.3 million. Interesting point is 75% are women, okay? They don't know why. They think it's a genetic factor, but there's no specific reason why the women are targeted on this one. The location for osteoarthritis is common in the hips, the knees, the lower back, the neck, feet, and finger joints. In the rheumatoid arthritis, it can appear on any joint, common in the hands, wrist, and feet, most likely. The joint stiffness for the osteoarthritis is mild in the morning, again, and occurs after a few hours of inactivity. Joint stiffness on the rheumatoid arthritis is prolonged hours of stiffness, many hours of stiffness, and takes longer hours to subside. They call them flares. You can be sitting there doing nothing, and you'll get this pain all over your back, or your hips, or your wrists, etc. They're called flares, and they usually reside after maybe a couple hours. So it's a little bit more tougher. The symptoms, again, the joint pain, stiffness, muscle weakness, and reduced motion. And you also get a creaking, so if you hear kind of a scraping type noise, it's bone on bone. Symptoms for the rheumatoid arthritis are the pain, stiffness, inflammation, the bumps, or nodules. One other thing is the fatigue is much more prevalent in the rheumatoid arthritis. There's also a great chance of running fever all the time. People very commonly do that. And loss of appetite. Rheumatoid arthritis people lose a lot of weight. This is important, especially in the nursing homes. When I used to go there or go there, you have to be careful, because if they lose a lot of weight, their body mass index changes. When the body mass index changes, the dosage of the medications that they're taking has to change too. And if nobody's checking the weight, nobody says, well, she lost 40 or 30 pounds in the last 2 months. That drug dose, a lot of the drug doses that she should have been on, or him, should be adjusted, lowered, or it could go up too. So that's important from that standpoint. So I have that on that sheet there for you. You can look at that when you get some time. And I'll talk to you about the other things here. So the rheumatoid arthritis, remember, is a chronic inflammatory disorder that can be affected. The thing with this too is it's an autoimmune disease. It can occur when your immune system mistakenly attacks your body tissues. I'm going to talk about your lungs, your skin, plaque psoriasis, etc., is rheumatoid arthritis. There's 7 plaque psoriasis situations that are out there. You see the ads every day. I'm sure you don't miss them. The big thing, too, the inflammation associated with the rheumatoid arthritis is what can damage other parts of the body as well. New types of medications have improved treatment options dramatically. Severe rheumatoid arthritis can still cause physical disabilities. Okay, Betty, next one. Okay, going back, the one on the left is a healthy joint. So you can see the joints, in the middle, you have cartilage on the top bone, you have cartilage on the bottom bone, underneath that is meniscus. So they slide, they're frictionless, they slide.
Yeah, you've got some cushion there.
Yeah, so you've got that cushion. Now the synovial membrane is what is on the outside, and that's, the blue part is synovial fluid, okay? So in osteoarthritis, you can see where it's wear and tear again. It's where it's worn down, it's swollen, and we're now touching bone on bone. The cartilage is almost gone, almost non-existent. On the rheumatoid, you can see where it is so swollen, and the bones essentially it's all gone. I mean, it's swollen. The synovial membrane, remember, it attacks the joints. Okay, so it's attacking the joints, and this could be not only in your knee, it could be in your hands, your feet, your fingers, your elbows, etc. Okay, so it picks wherever it wants to go, and you just never know. So you got good to not so bad, to not so good, and to really bad. Okay, so the osteoarthritis, again, pain, stiffness, tenderness, loss of flexibility, the grating or the grinding, bone spurs and swelling. The rheumatoid, tender, warm, swollen joints, joint stiffness worse in the morning and afternoon, fatigue, fever, and loss of appetite. Okay, so I know some of this is repetition, but it works.
Does weather affect either?
Weather is usually not. They always say if it's raining, you know how it does that. No, it doesn't. Temperature more than anything. If it's really cold, and you go outside, you're going to probably feel it more than if you're going to go outside in Arizona, etc. So early rheumatoid arthritis tends to affect your smaller joints first, particularly the joints that attach to fingers in your hands and your toes and your feet. As the disease progresses, symptoms often spread to the wrists, the knees, ankles, elbows, hips, and shoulders. In most cases, the symptoms occur at the same time in the same joints on both sides of your body. Osteoarthritis, it's one side. It might just be your hand or your wrist, but on rheumatoid arthritis, it's both. So both sides are affected at the same time in rheumatoid arthritis. So, and that's important too. So that's another way that the doctors can diagnose this too. So about 40% of rheumatoid arthritis people also experience signs and symptoms that do not involve the joints. Areas that may be infected include the skin, your eyes, your lungs, your heart, your kidneys, salivary glands, nerve tissue, bone marrow, and blood vessels. Rheumatoid arthritis signs and symptoms may vary greatly in severity and may even come and go. So that was what I was talking about when you get those flares, when the swelling and pain fade to disappear. Over time, rheumatoid arthritis will cause the joints to deform and shift out of place. Okay? So that's where we need the proper diagnosis to come in. Okay, Betty, next slide. Okay, I'm not going to scare you, but I'm going to tell you, this is the complications, and this is coming from Mayo Clinic. So some of the complications of rheumatoid arthritis are osteoporosis. Rheumatoid arthritis itself, along with some medications used for treating rheumatoid arthritis, can increase your risk of osteoporosis, a condition that weakens your bones and makes them more prone to fracture and hip problems, especially hip fractures. Rheumatoid nodules, these firm bumps of tissue mostly form around pressure points, such as the elbows. However, nodules can form anywhere in the body, including the heart and the lung. So we're talking about in the lung, in the heart, not these nodules growing. Dry eyes and mouth. People who have rheumatoid arthritis are extremely likely to develop Sjogren's disease, Sjogren's, a disorder that decreases the amount of moisture in the eyes and the mouth. So when I was doing my nursing home gigs, one of the things I would run into, and this goes back about 30 years ago, or actually 25 years ago, where I would go in, and the nurses would complain that Mrs. Jones wakes up with really dry mouth or dry eyes, and back then we didn't have like over-the-counter products like Biotine. So I contacted Mayo Clinic, and we came up with a kind of a unique solution. It's still used today, is that for the mouth, when it's really dry, they use a pilocaine eye drops, which is also used for ophthalmic drops used for dryness in the eye too. So they put 2 to 3 drops on the mouth 2 to 3 times a day, and that takes care of that. If there's too much mucus, we switch to atropine eye drops. And so this causes a lot of problems in the pharmacies when I go to. I'll be standing there, and a technician will come up and say, "Tim, I think the doctor made a mistake here. He wrote for pilocaine eye drops, and it says 1 to 2 drops in the mouth 4 times a day. Shouldn't it be eyes? You need to call." So I look at it and I say, no, number 1, she's a nursing home patient. Number 2, she's in her 80s. You know, when we've all visited nursing homes somewhere along the lines. It's so hot in there. They keep it's so hot. There's no humidity. It's so dry, and that becomes of that. Today we have Biotin and some of these over-the-counter products, mouthwashes that they use, but they still use. I still see or saw, even until I retired a few years ago from the retail pharmacy, and I still saw a lot of that. Infections, rheumatoid arthritis in itself, and many of the medications used to combat it can impair your immune system, bring it down. So what does this mean? Leading to increased infections. Protect yourself with vaccinations to prevent diseases such as influenza, pneumonia, shingles, COVID-19, and now RSV. So remember, your immune system is dragged right down. Abnormal body composition. The proportion of fat, I talked about that, to lean mass is higher in people who have rheumatic arthritis, especially see it in the nursing home. And so we need to adjust the dosage of their medications. Carpal tunnel. Carpal tunnel is a rheumatoid arthritis. On that sheet I gave you, I'm not going to spend any time on it, but there is a definition of the carpal tunnel on there for you, and it'll talk to you that. Just so you know, for those that, some of you may know that have already had surgery on it, or you get cortisone shots like I do for that, for carpal tunnel, you need to, it's kind of weird because for Medicare, you can go to your regular physician. Your regular physician will take x-rays, ultrasounds, whatever, and he says, yes, you have carpal tunnel. So he sends you off to your orthopedic surgeon. Your orthopedic surgeon takes x-rays, ultrasounds, etc., and says, yes, you have carpal tunnel. Not good enough for Medicare. So no surgery. So then the Medicare says, you got to go to, it's called Minneapolis Neurological Clinic. I don't know if there's one out here, but there's one just not far from us up by the hospital in Maple Grove. And you go there, and it takes about 3 or 4 months to get in. And you go there, and I was there, and there must have been about 60 people waiting in the lobby. And what they do, on each arm, they put all these little probes on there, and then they sit there, and they send shock waves, electrical shock waves, into your hands one at a time, and it reads out like an EKG thing. And then you get this big printout, and that goes to a rheumatologist or another doctor, and they have to okay for you to have surgery to be covered by Medicare. So it's called an EMG, electromyography, and you have to have that done before Medicare will consider that. Then you have to go back and see your orthopedic surgeon, and if it passes, then you're set. So just so you know that you just can't go in and see your doctor and say, I got a carpal tunnel. That's not going to work.
So you need to do a few steps, and do they kind of walk you through?
Yeah. Oh, yeah.
That's going to be your next step, and then you're going to do the next step.
Yeah. So you'll see those clinics are all over the Twin Cities, Minnesota Neurological, and that's one of the things that they do. So, and they're booked constantly. Okay. Another one is carpal tunnel syndrome. Rheumatoid arthritis affects your wrists. Heart problems. Rheumatoid arthritis can increase your risk of hardened and blocked arteries, such as inflammation in the sac that encloses the heart. Lung disease, rheumatoid arthritis has an increased risk of inflammation and scarring of the lung tissues, which can lead to progressive shortness of breath, or COPD. Lymphoma, rheumatoid arthritis, has been linked by the Mayo Clinic and some others, increases the risk of lymphomas, a group of blood cancers that can develop in your lymph system. Okay.
So is the important thing to note that if you have rheumatoid arthritis, especially, that you go and get regular checkups?
Absolutely.
And just to be aware of this.
Some of the criteria on the right side that the physicians use, arthritis of the hand for 6 weeks, at least 6 weeks, arthritis on both sides of the body, rheumatoid nodules under the skin, rheumatoid factor, and I'll talk about that in just a sec. Morning stiffness, the arthritis of 3 or more joints at one time for at least 6 weeks, and evidence of rheumatoid arthritis using x-rays, etc. So, next one, Betty. So the blood tests that they use it's called the elevated erythroid sediment, ERS, which is known as the SED rate, or C-reactive protein. This is what they use to indicate the presence of inflammatory process in the body. Then on top of that, they'll use x-rays, MRI, and ultrasounds. There is no cure for rheumatoid arthritis. There is no cure for osteoarthritis, to make that very clear. So, go ahead, Betty. So, treatment. What do we use for rheumatoid arthritis? Treatment begins early as soon as we can get them. They're called DMARDs, disease-modifying anti-rheumatic drugs. There are about 12 of those out there. They've been out there. Some of those have been out there for a year. Some of you people may be on them. It's not uncommon. So what they use are non-SEDs, or like ibuprofen and naproxen. Steroids like prednisone, they use high doses, then they use short doses for a short period of time. Conventional DMARDs are called such as methotrexate, hydroxychloroquine. These are the big three, and sulfasalazine. They're also anti-cancer drugs too. The biological agents is the newest class. This is the one I want to talk to you about. They are called, let's put it this way. When you have a new drug, then you can make a generic after this patent runs out. The new class is called biologics. Biologics are essentially a living cell in, let's say, microbes, etc. So it's hard to explain, but they're living cells of microbes. The thing with biologics is you cannot replicate them like you can a generic. Then they're targeted for a certain area in the body, the immune system, and then they're called biosimilars. You're going to see this terminology used a lot. There are a lot of biosimilars or biologics already out there. There's like 9 of them, and most of them are injections, but you might be using those down the road. So biologics and biosimilars are the 2 new class. Physical therapy, of course, comes in hand. If your doctor, not all the previous things above are working, they go to a synoviomectomy, which is a removal. They'll remove the inflamed lining of the joint. Or they'll do a tendon repair, where they'll repair the tendons around the joint, hopefully straightening out your joint. They have a joint fusion. They fuse, if the bones are apart, they'll fuse that joint together to stabilize. And otherwise, they'll do a total joint replacement. A lot of us have had that done. So the exercise, applies heat, and everything is really important. So you can go to the next one, Betty. Okay. So we're going to talk about osteoarthritis mainly, because I'm not going to talk about all those biologics and everything. It's not a big. You guys will see more of that as you go along. But I just wanted you to know, if you see that, it's in there. It was in ARP last month, and the current issue of Arthritis Foundation's current magazine that I get was in there. There was an article in there too about them. So for the 32.5 million people, pain can be an everyday occurrence. The treatment, over-the-counter medications, are to slow the progression of osteoarthritis, manage the symptoms, and keep you mobile, keep you moving. So what are these meds and how do they work? So the non-steroidal anti-inflammatories are the most effective OTC remedies for managing osteoarthritis pain. And this is coming from the Academy of Rheumatologists, the Arthritis Foundation, and the orthopedic surgeons, the Council on Orthopedic Surgeons. From here on in, I'll just call them the experts, or the experts. NSAIDs are one of the most effective over-the-counter medications for managing osteoarthritis. The NSAIDs can help reduce both the pain and inflammation, and they also reduce the body temperature. The following NSAIDs, which I have a list on that sheet for you, are the ibuprofen, the naproxen. Aspirin is a NSAID. Nabutone, Relafin, which is prescription only, and only within the last few years, diclofenac sodium topical gel. This is a NSAID, but it's over the counter. Used to be a prescription. I'll talk about that in a sec. It's currently Aspercreme or Voltaren is the name. Okay, Betty. So the NSAIDs essentially work by reducing your body's production of substances called prostaglandins. When you get hit in the arm, prostaglandins are released by the blood, and it's a lipid that thinks it's a hormone. And when the hormone does it, they cause inflammation, they cause swelling, cause black and bluing, etc. And your pain. That's where you get the pain from. So the NSAIDs they'll reduce the pain and lower that inflammation and then swelling to your joints. Now, all NSAIDs except aspirin increase the risk of heart attacks and strokes. So you have to be a little careful. So NSAIDs side effects can lead to stomach upset, ulcers, gastrointestinal bleeding, wheezing, and if you're an asthmatic, already taken an inhaler, not good. Hives, change in the kidney function, and rash. So if people are on too many NSAIDs, they usually have the kidney function is done by a creatinine test, and I'll talk about that too. So NSAIDs also reduce blood clotting. So people often take aspirin, for example, such as blood thinners, if they have a high risk for heart attack. So got to be careful if you're doing that. So there are no recommendations for topical steroids for the hip osteoarthritis at this time. Usually the only thing you can use is oral tablets. If you can't tolerate that, then well, they try and, if you can't tolerate the NSAIDs, then they put you on ones that are, that they use for the knee, called duoxetine or Cymbalta, and some of you might be on those now. So if they're put on NSAIDs for a long period of time, and on your chart, I put a thing that's called PPIs, it's protein pump inhibitors. They want you to go on that. That reduces the acid, so if you're on a NSAID, it won't tear your stomach apart. There's, I wrote them there, the Nexium, the Prevacid, Prilosec, and the Zegradard. They usually run about a 14, the doctors will put you on a 14 to 21 day course of therapy with that. Prilosec OTC is 20 milligrams, the prescription is 40. So it kind of depends what you and the doctor, but usually if you're going to be put on that by a long period of time, you will be on one of those. So always follow your doctor's instructions on those. Okay, Betty, next. So we'll talk about Tylenol. Tylenol can reduce the pain, but it won't decrease joint inflammation. For this reason, it's only recommended if you cannot use the steroid or the non-steroidal anti-inflammatories. Taking large amounts of Tylenol over time or using too much with alcohol can lead to liver damage. Current recommendations are to limit the amount of the Tylenol to about 3,000 milligrams. It used to be 4,000 about 10 years ago. 5 years ago, they went to 3,500, and now the ones now are 3,000. One of the reasons is I get a drug report. It's called the drug-induced liver injuries, DILI, drug-induced liver injuries. The number one culprit from the first 6 months of 2023, and it is almost every month, is acetaminophen, by far. It had 1,700 drug-induced injuries. You compare that to ibuprofen was 544, and if you're on a statin, Lipitor is by far the worst one, is right behind the ibuprofen. It was number 7, I think. So just give you, but it's called drug-induced liver injury. So acetaminophen was number 1 by far. If you are on a statin, and I get this question asked all the time, if you are on a statin, they're always testing for enzymes. And if it's a statin, like atorvastatin or Lipitor.
Which is for blood pressure?
No, it's for cholesterol.
Cholesterol.
For cholesterol. And then what happens is they test for the enzymes. And it's a long, like 26 vowel enzyme, and it's referred to as ALT, ALT. So if you're on a statin that requires a cholesterol medication that requires that goes through the kidneys, then you're looking at the kidney, it was just the creatinine level. And that's usually part of your wellness visit. So they usually check all those. So don't be afraid to ask the doctor about those at all. So just kind of know which one you have and which way it's broken down in the kidneys. Okay, Betty, you can go next. So some of the people always ask about the herbs and the supplements to treat osteoarthritis. Vitamin D. Vitamin D just finished a 5-year study at the Mayo Clinic. Was tested in units. There was 6,000 people that were given 2,000 units a day to reduce statin or the cholesterol-associated muscle pain. It's a 5-year study, but vitamin D failed to show any people were telling you that the vitamin D is going to do this. No, it's been proven. Fish oils. Now, the one that I always see on TV is Omega XL. You've probably seen those ads. That is from the waters of New Zealand. It's green-lipped mussel oil is what it is. And it's got pure olive oil, omega fatty oils, or fish oil, and vitamin E. Again, nobody's proven that it does any anti-inflammatory. They say it does all this, but it's not proven by any of the big societies and everything like that. So kind of like Prevagen for Alzheimer's disease, that got shot down last spring by Mayo Clinic, that it's ineffective, totally ineffective. The FDA does not regulate any of these products, so you have to be a little careful, so you can't be sure of what you're getting on all these, okay? So just because they've got people that say they work really well, we all know how far that can go.
Yeah, and there are lots of ads that tell you other things. So.
And that Omega XL, I just happened to see the other day, I think it was 2 bottles for about $75, and they threw in a free bottle of vitamin D. So, anyway, so it probably doesn't do too much. Now, we'll talk, okay, glucosamine, I want to talk about that. There's 2 types of glucosamine. Go back, Betty. Okay, glucosamine has chondroitin, and the chondroitin enhances the cartilage. It beefs up the cartilage. With MSN, if you get it with MSN, it's methylsulfomethane. That's a lubricant, okay? It helps the hair, skin, and nails as well. According to the experts, they recommend against the use of glucosamine for the hip and the knee, but they do recommend it for only the hand. For hand osteoarthritis, they do recommend it for that. So it promotes the production and prevents the degradation of cartilage. Okay? Okay, so try to move along here. Getting there. Okay, you go into a pharmacy, you're not sure what you should buy. I want to talk about a couple things. This is Aspercreme, which it's been around forever. Voltaren was a prescription up until about 5 years ago. Used to be one of the top ones that we would dispense. And the generic, the one in the middle is the arthritic pain reliever. These are all the same. That's the non-steroidal diflonic acid, okay? This is the only over-the-counter diflonic acid. So topical pain treatments often work in one of these ways. They distract you from the pain, they block the pain signals from reaching the brain, they numb the area, and they reduce the inflammation. Topical solutions have been demonstrated to be associated with fewer side effects, specifically gastrointestinal reactions than other pain medications, such as non-steroidal and anti-inflammatories. Okay. So there are 5, there's going to be 5, I'm going to show you 5. They're on your list. These are the 5 that are approved by the experts. Lidocaine, which is a local anesthetic. If you look at that salon box, I'll get back to it, but it tells what areas, the back, it's the knee, elbows, etc. It tells where it's effective. Methyl salicylate, which is actually part of the non-steroidal family, it's made of wintergreen oil, and it dilates the blood vessels, providing a sense of warmth. Menthol, which is found in mint plants, opens the blood vessels and increases the blood flow and provides a cooling effect. So when you see big old Shaquille O'Neal rubbing icy hot on there, I can tell you right now, it's methyl salicylate, the warmth, the hot, and the menthol, giving them the cool, because when they go on. So, okay, Betty. So the other 2 are Capazian, which came out probably 30 years ago, was the only one. It used to be a prescription. It's made by found in chili peppers. It reduces back pain really well. It's excellent on back pain by deleting the chemical that signals the pain to the back. Camphor is the 5th one. It may create a pain-relieving analgesic effect by activating and desensitizing the specific pain receptors when applied to the skin. If you notice that Bengay there, if you look, we've got camphor, methyl salicylate. We got 3. There's 3 of those right there.
So
no
they're
magic.
all topical.
Yeah, they're all topical. No, there's only these 5 are recommended. Okay, ready to go to the next one. So if you go to take Aspercreme, and for you mathematicians out there, there's creams, rubs, roll-on, sprays, and you take 5x4 and the permutations, and you figure out how many Aspercremes there could be with just those 5, it's 120 products. No way can anybody put that on their shelf. And so they don't make all of those. But that's the possibility of all these if it's menthol or if it's got camphor, there's a possibility in some of these of 120 projects. Okay, Betty, next one. So which one do you choose? Well, you go into the pharmacy, you're going to know what area you're going to want to treat. You want to make sure that it's going to have one of those products. If it doesn't have one of those products, then go ahead and get the non-steroidal anti-inflammatory. I use this one. It comes in a gel, cream, and some other ones, and there's many generics out there. But the cool thing about all these products, including that Salon Pass, look at the box. You know where you want to treat. it'll tell you exactly where you can use it. And down below it says where you cannot use it. Okay? So if you know you want to get something like this for your elbows, it's great. The pain reliever, that'll be the most effective. So look at that. You don't have to have a pharmacist or anybody help you. You can see you can do it yourself. So go ahead, Betty. So we'll skip that one. This is on your handout. It'll tell you where the non-SED tablets are most effective, where the topical pain relievers. There are no creams or gels for the hips recommended. Back pain, the lidocaine, the methyl salicylate, menthol, capazian, camphor, and then TENS machines. I don't know if you people have TENS machines, but go ahead, Betty. It goes on. It numbs the nerve endings. It's a transcutaneous electrical nerve stimulation. Go ahead. You went backwards. You went backwards. Oh, yeah. I was going to tell you about that one, but we will skip it. Are we missing something? Yeah, go past it. Okay, so the TENS machine, if some of you have them, otherwise they're about $50 or $60. You can put them on shoulders and stuff. They stimulate like if you're at a chiropractor's office. Weight management, exercise, relaxation strategies, and stretching are your key. So go ahead, one more. For you people that are interested, you can go in the pharmacies and the doctor's office. It's called the Minnesota Immunization Information Center, and I put the link there for you. You can go there, and they will send you out. Go ahead, Betty. Next one, I'll show you. They'll send you out a printout of all your immunizations up to date, current. Okay, and it's no charge. You get it in about 3 weeks, or they will email it to you in about 2 weeks or less. So just follow the instructions. I put them on the sheet there for you, so you can easily follow. And then one last thing, I think. Oh, goodbye.
Yeah.
I'm kind of sorry we rushed through it a little bit, but we had a. I think we did pretty good.
Yeah. Do you have questions? Yes, Chris.
So I have had a lot of arthritis for a lot of years. I've had joint replacements, joint fusions, all kinds of different things. But my biggest problem is that I'm allergic to the non-steroid anti-inflammatory drugs, all kinds of classes of them. And the only thing that I feel like I can take is Tylenol, which doesn't really do a whole lot. So all these creams that you're talking about, like the Voltaren one, for instance, says, if you're allergic to the NSAIDs, don't use it. So what else is there that you can do if you can't use any of these other products?
So you can't use non-SEDs, even the topical creams or gels, if they work. Okay, and so you'd be looking at corticosteroid shots, probably steroid shots, cortisone of some type. Or surgery, probably, if you get down. Yeah, so you try to avoid that by using the over-the-counter products as best you can. So, and for most people, they're temporary.
Is only the Tylenol is what she's saying.
Oh yeah, if you can definitely take Tylenol if you can't take.
But
the
it doesn't
non-SEDs.
do much.
Yeah, but the inflammation part is what it won't do, but it will help. It will take care of the pain. So it's not a problem. It doesn't do that either.
Not really.
Yeah. So you're to the point where you need to move on to the some of the prescription items like Cymbalta and et cetera that I just mentioned. So that would be your next. If you've talked to I'm sure you've talked to your physician by now. So yeah, we see it in the pharmacy a lot. So and it's just a matter. Then they end up sending you to a rheumatologist or somebody or something like that. But yeah, it's a little bit of trial. It's definitely trial and error. So what works for me may not work for you.
So you said though that carpal tunnel is a rheumatoid arthritis?
What was that?
Yeah, you said that carpal tunnel was a rheumatoid arthritis.
Carpal tunnel is classified by the rheumatologist as rheumatology. Yeah.
But all the other arthritis that I have, they say is osteo.
Yeah, this is coming from Mayo Clinic, so it might vary from rheumatologists, but this is coming from Mayo Clinic. This is coming from Mayo Clinic, And this is as of last year, so this is because I did this last year, or this spring, so for the Trinitarians, so.
What
But-
about those was it biomodule?
Oh, biologics?
Yes,
Yeah.
biologic.
Would they help? Yeah, it's possible. There are injections there involved. Only certain people, you have to be in a certain class to qualify for that. You'd have to go to a rheumatologist, probably to qualify for those. But we have some people here that are taking the oral medications, methotrexate, those 3 that I mentioned. We have some of the people that have talked to me in this congregation about those medications. So that would be another step up. They're another step. Yeah, check with your physician. Yeah, you would check with your physician. You'd probably have to get a referral to be able to do all that. So I've been jumped through those hoops, but and of course, if you have the carpal tunnel, you have to get the authorization from usually your orthopedic surgeon is the one that will get the authorization to get that done. So you can't just walk in there, yeah. Oh, yeah. I know, I got it, and I elected for the shots. So I got the cortisone shots just last spring. I've been doing fine. No numbness, no tingling. And they normally don't last for about 6 to 9 months, but I've had no problems at all. So it's been, we feel really good there. So, but, it's an individual thing. Will I go back and get one? I think they allow you about 3 shots, and then 3 years worth, then they figure you should get the carpal tunnel. Then you should have the surgery. So, but it varies from clinic to clinic, as far as I know. So.
Tim, how do you feel about CBD creams and treatments?
Which one?
CBD,
CPD.
cannabis treatments?
Oh, the cannabis. I don't know. I haven't seen where anybody's proven that it's that effective yet. So for the Pharmaceutical Association is they're kind of wait and see. It's a wait and see attitude. So they're right up here in Otsego, by the way. Most of that stuff is made, and I had a chance to actually work there if I wanted to, but I didn't want to really do that. So I decided to stay away from that stuff. But I think in time, I think the treatments and everything will be more refined and be more targeted. And I think they might be effective for a lot of people in time. I really do. So,
Yep,
but
yep, it's new.
I think right now it's a little bit out of control because everybody's there. It's all over
Yep.
the place. Nobody seems to have control on the dosages, on the amount that you can get. There are some things like that, but it seems like
Yeah.
everybody's got it. So I'm not sure if it's going to work or not. But time will tell. There's a lot of clinics that are working on this medication.
Yeah.
So.
Gail.
I've had some issues with thyroid. I had hyper and slow thyroid, and I stopped eating gluten, and that put me in remission of all that, and now it's normal.
Stop using what?
I stopped eating gluten.
Oh, gluten?
Wheat. And as a side, because that's an autoimmune thing too, and as a side effect of that, all the arthritis in my hands, I've been doing that for about 6-7 years now, that had subsided, and I didn't have as much issue. Now I have in my little finger started, but I anyway. How do you feel about if you're alert? So I'm sensitive to gluten, so I stopped eating that, and then that stopped the autoimmune thing.
I've seen some studies on that by a lot of big clinics in the United States, and that has come up for discussion on many webinars that I attend and some meetings and stuff. That comes up quite often. I guess the data isn't quite there yet. The studies aren't there. Some of those I mentioned are 5-year studies, and so the gluten one, people stopping the gluten, having their arthritis all of a sudden become much better is very common, but studies are underway on that. So I guess I would tell you to stay tuned. The Arthritis Foundation had an article in there about last year that I read in one of their magazines. I belong to that group also, and it talked about that, and it was pretty much the same thing, that There's a clinic in, you've heard of Oxford University in England. Well, in the United States, it's called the Roth Clinic. It's in Mead, Boston, or outside of Boston, Mead, Massachusetts. And it's like the Oxford University, and they're doing studies on that right now. And the stuff that comes out of there, let me tell you, if Oxford says it's good, and this clinic says it's good, let me tell you, I don't care. And we talk about that a lot in Alzheimer's, that these studies are continually going on. So, but your study is a continuous study. It's in a work in progress, I would tell you. Yes, I have seen that. They've had numbers of people that they had maybe 1,000 people that they had tested over a 2-year or 3-year period and have found that to be effective, yes. So they're not sure why. There could be a genetic effect, a factor here. They're sure why. So I guess stay tuned. We'll see.
Yep. And talk to each other. I mean, certain things work for certain people.
Absolutely.
Right?
Absolutely.
Yeah. I had hip surgery after I injured, and I thought I had in my other knee arthritis. And when I asked my physician, he said, I think it's just a ghost arthritis. Like I was just feeling that because of my other side, and he was right. So, I mean, you don't know, and I think talking to Tim and talking to friends, you learn, just like what Gail talked about, going gluten-free. I mean, it's working for her pretty well.
And getting that proper diagnosis is, believe me, it is number one. My orthopedic surgeon again said he cannot name the number of people that have come in, thought they had something a lot worse than they did, and they had the wrong diagnosis from another doctor. So that's why I said, so don't hesitate to go as high as you can to get the best diagnosis you can. So
Thank you for coming.
yes, appreciate
Thank you so
it. And
much.
there's a lot of information, but try to kind of put it through in a fast way.